We're going to call the meeting to order. Rise for the Pledge of Allegiance, please.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you, everyone, and Happy New Year. Good to see you all again. Dee, would you please take the roll?
Director Wallace.
Present.
Director Nicholson.
Present.
Director Yee.
Present.
Director Eapen.
Present.
Director Stewart.
Present.
Thank you. Okay, we're going to move to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar?
No.
Thank you. Does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve the consent calendar items A through C?
In accordance with district law policies and procedures, I move that the Board of Directors approve the consent calendar items A through C.
Thank you.
Second.
Thank you. Dee, would you please take that?
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Eapen.
Aye.
Director Stewart.
Aye.
Any oral communications this evening?
There are none.
Thank you. Okay. Good evening, Dr. Killaroo. Good to see you.
So we have a slew of new appointees. Starting off, Dr. Aras Mandar, Medicine Cardiology, starting as provisional consulting. Dr. Shoban Finn is a physician assistant joining the emergency room department. Ryan Garcia is a physician assistant joining the cardiac surgery team. Dr. Ashley Lee is a radiation oncologist, provisional active. Dr. Sean Lucas, anesthesiologist, provisional active. Ziba Mundu is a physician assistant joining the emergency room department. Dr. Shirag Patel is an oral maxillofacial surgeon, provisional active. Dr. Ronald Robinson, family medicine, joining Sound Physicians as a hospitalist, provisional active. Dr. Roger Ruby, family medicine, joining Palo Alto Medical Foundation, provisional active. Dr. Chai-Ding Shi, podiatry, provisional active. Dr. Sabarjit Singh, internal medicine hospitalist with Sound Physician, provisional active. Dr. Tiger Tejpal Singh, diagnostic radiology, provisional active. And finally, Brianne Wong, physician assistant, joining Dr. Dearborn. For the temporary privileges, Ryan Garcia, the physician assistant for cardiac surgery. Dr. Mehran Jamali, asking for critical care level 1 privileges. Dr. Sean Lucas, anesthesia. Zuba Mundu, emergency room physician assistant. Dr. Ronald Robinson, family medicine. Dr. Geeta Singh, level 1 critical care privileges. Dr. Sabarjit Singh, internal medicine hospitalist. Dr. Tiger Tejpal Singh, diagnostic radiology. And Brianne Wong, physician assistant, are all requesting temporary privileges. 30-day extension request for Priyanka Galwani, internal medicine, and Dr. Robin Patel, anesthesia, as well as William Gadea, physician assistant for Dr. Begi, Dr. Timothy Ortlop, otolaryngology. 2-year reappointments, we have Dr. Lisa Arcilla, pediatric cardiology, and she's going to be moving from active to ambulatory. Dr. Cesar Devaharian, emergency room physician. Dr. Aditya Jain, interventional cardiology. Dr. Peter Lunny, nephrology. Dr. Rohit Sehgal, interventional cardiology. Dr. Shirley Sai, pediatric hospitalist. Dr. Albert Wang, internal medicine. Dr. Jacqueline Wei, orthopedic surgery. We have 1-year reappointments for Dr. Zulfikar Ali, cardiology, and Dr. Ramin Begi, cardiothoracic surgery. Transfer and staff category, as I mentioned, Dr. Lisa Arcella, pediatric cardiology, going from active to ambulatory. Completion of proctoring and advancement in staff category, Dr. Toshi Hiroka, emergency medicine, Dr. Timothy Ortlip, otolaryngology, Dr. Nora Paff, pediatric hospitalist. Extension of proctorship in provisional category for 1 year, Dr. William Gadea, physician assistant for Dr. Beghi, Dr. Timothy Ortlip, otolaryngology. New privilege requests for Dr. Mehran Jamali for critical care level 1 privileges, Dr. Geeta Singh, also critical care level 1 privileges. Conflict of interest statement has been updated by Dr. Cesar Devaharian, emergency medicine, Dr. Aditya Jain, interventional cardiology, Dr. Peter Lunny, nephrology. Leave of absence for Dr. Kalgi Parmar, podiatry. And resignations, we have Dr. Manish Bhamani, emergency medicine, Dr. Maggie Jones, internal medicine, and Dr. Curtis Wozniak, cardiac surgery.
Thank you, Dr. Killaru. May I have a motion for approval of the credentialing action items?
Mr. President, I move that we approve the medical credential items as presented.
Thank you.
Second.
Thank you. Dee?
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Epen.
Aye.
Director Stewart.
Aye.
Okay, that motion passes. Kimberly?
Right.
Hi.
Yes, we have a presentation this evening by Dr. Lawrence Tigalau, and he is going to be presenting on this new maternal health legislation in California. And I just want to give you a short background on Dr. Tigalau. He was raised in Arlington, Virginia. He has a Bachelor of Science degree in anthropology from UCLA and a medical degree from Oregon Health and Science University in Portland, Oregon. He completed his residency in obstetrics and gynecology at UC Davis. He has been the medical director for the OB hospitalist group at Washington Hospital since last year. Prior to this, he was a private practice with Los Olivos Women's Medical Group, Stanford University Healthcare Associates in Los Gatos. And in his spare time, he enjoys international travel and spending time with his 3 very active sons. So, Dr. Tigalau, thank you.
Thank you for the invitation to speak today. Thank you for the introduction, Kimberly. The title of my talk is No Mother Left Behind, and it addresses the adoption of the Maternal Mental Health Conditions Education, Early Diagnosis, and Treatment Act. We're getting conflicts of interest out of the way. I have none to declare. And the objectives of our talk are to raise awareness about maternal mental health disorders, discuss recent changes in legislation in the state of California, and discuss adoption of these changes at Washington Hospital. The California Assembly passed Bill 3032 on September 26, 2018, and they named it the Maternal Mental Health Conditions Education, Early Diagnosis, and Treatment Act. The bill requires that general acute care hospitals or hospitals that have perinatal units develop and implement by January 1st, 2020, a program relating to mental health conditions, including but not limited to postpartum depression. This bill requires the program to include, among other things, education and information about maternal mental health conditions for women, families, and the hospital perinatal unit employees as specified. Maternal mental health conditions encompass a number of disorders or conditions, including depression and postpartum depression, anxiety, postpartum psychosis, post-traumatic stress disorder from traumatic deliveries such as emergency cesarean sections or operative deliveries, bipolar disorder type 2, obsessive compulsive disorder, and postpartum panic disorder. This list comprises the most common conditions that we see, and there are many more that are not named. The impact on women and infants is significant. According to the CDC, 11 to 20% of women in the postpartum period have some form of depression. It is the most common complication of childbirth by far. Approximately 600,000 women get postpartum depression each year in the US alone. Half of those women diagnosed with postpartum depression, for half of them, it's their first episode of depression. And half of women who are diagnosed with postpartum depression experience symptoms during pregnancy. This is significant in that only 15% of women with postpartum depression ever receive professional treatment. So out of the 600,000 women that are diagnosed, only there are about 510,000 that are left untreated. Untreated depression in the peripartum period can have devastating effects, including adverse birth outcomes, such as neonatal demise or intrauterine fetal demise, impaired maternal-infant bonding, poor infant growth, childhood emotional and behavioral problems. And they also come with, if left untreated, significant and economic costs estimated to be $22,500 per mother. Postpartum depression can be mistaken for other conditions such as baby blues. Baby blues is a condition that affects 50 to 85% of mothers within the first 2 weeks of pregnancy, or of birth, excuse me. Symptoms include irritability and anxiety and fluctuating mood, but these symptoms are usually mild and occasional. Women with postpartum depression can be diagnosed within the first few weeks. Clinically, it's usually at 2 weeks and up to 12 months postpartum. Depression from childbirth typically arises from a combination of hormonal changes, psychological adjustment to motherhood, and fatigue. We, as physicians, try not to confuse postpartum depression with baby blues, and the big difference, again, is that these symptoms tend to fade after 2 weeks. Anybody who still has symptoms after 2 weeks has postpartum depression. Risk factors for postpartum depression include depression and anxiety during pregnancy, experiencing stressful life events during pregnancy or the early postpartum period, such as loss of support, loss of family members. Women who have babies that are admitted to the NICU are at high risk for postpartum depression. Women who have low levels of social support are at risk, and those who have a previous history of depression. And what's not listed here is also breastfeeding difficulties is known to be a risk factor. The symptoms of postpartum depression, this is a pretty exhaustive list that can be summarized by our diagram here. Women who experience postpartum depression will often feel sad, hopeless, empty, or overwhelmed. There can be worry or anxiety. There can be sleep disturbance, such as oversleeping or not getting enough sleep. Some of our patients have trouble concentrating, remembering details, and making decisions. Some have unexplained anger and rage. Some of our patients lose interest in activities that are usually enjoyable. Some have frequent headaches and stomach problems and muscle pains and other physical symptoms that can't be explained medically. There's a change in appetite. There can be withdrawal from friends and family, and there can be trouble bonding with their infants. Most importantly, and what we try to detect are women who are at risk for harming themselves or their infants. So how do we detect who's at risk? We screen, and screening allows for early detection. It's a way for us to find who is at highest risk and may be present in the early postpartum period. It's important for us to screen early, as maternal mood within the first 2 weeks of childbirth is a predictor for postpartum depression. There can be a high false positive rate within the first 2 weeks, as depression can be mistaken for baby blues. Therefore, a retest is needed after this period to get the best detection rate. This is a table that contains all the most commonly used depression screening tools. Here at Washington Hospital, we utilize the Edinburgh Postnatal Depression Scale. It has 10 items and takes less than 5 minutes to complete, and has relatively good sensitivity and specificity. The questions on the tool are related to maternal feelings during the past 7 days and refer to depressed mood, anhedonia, which is reduced motivation or ability to experience pleasure. Questions are related to guilt, anxiety, and suicidal ideation. The nice thing about this tool is that it excludes changes in sleeping pattern, which is common during pregnancy and the postpartum period. It is convenient, it is culturally neutral, it can be translated into 50 different languages. It is very low cost, and it can be incorporated into everyday practice. This is a screenshot from Epic and shows the table in which a provider would enter in the scores for postpartum, the scoring from the postpartum depression scale tool, and it shows the questions. It asks whether our patients are able to laugh and see the funny side of things. Have they looked forward to enjoyment, to activities? Do they blame themselves unnecessarily when things have gone wrong? Do they feel anxious? Have they felt scared or panicky for no good reason? Do they have a weight on them? Have they felt so unhappy that they've had difficulty sleeping? Have they felt sad or miserable? Have they been so unhappy that they've been crying? And lastly, yes, the most important question is the thought of harming themselves or others. From the scoring, answers are usually given, it's a multiple choice tool, and answers are given a value from 0 to 3. And these answers usually correspond to always, most of the time, rarely, or never. So these are our nurses from labor and delivery. They're very happy. How have we incorporated these tools into our practice? Putting it all together, the pre-admit nurses will screen patients with the EDS scale prior to admission for baseline. Postpartum, the nurses will screen the patients 1 to 2 days after delivery. Patients with babies in the special care nursery will be screened weekly by the social worker. And every time a patient's evaluated, these results will be entered into Epic. How will patients and their families be educated about postpartum depression? This is a copy of the pamphlet that we'll be giving out or are giving out to our patients. And it neatly categorizes, it has the patient's emotions and feelings that they might be feeling, and can provide feedback on whether or not they perhaps should seek help right away, or it provides reassurance that some of the feelings that they are experiencing are normal. For instance, if you look at the first, the top, if we have a mom who's having trouble managing her emotions or is just not feeling like she's herself, she can look on the left side of the handout and see that these feelings could be normal for moms who are to new moms, and they're reassured that these feelings typically go away after a few weeks. For patients with moderate symptoms, here in the yellow boxes, for instance, if a patient is having intense anxiety or is having scary, upsetting thoughts that don't go away, those patients are at higher risk for postpartum depression. And so they're encouraged to contact their OBGYNs. There's a phone number for Postpartum Support International, and they're encouraged to also talk to their partners, families, and friends. For patients with severe symptoms, who are feeling hopeless and having total despair, feeling like they might hurt somebody else, they're encouraged to call 911 right away. There's a phone number for the National Suicide Prevention Lifeline, and also a phone number for the Substance Abuse Mental Health Services Administration National Helpline. And they provide screening and recovery services for patients. What do we do for our patients at risk? And our approach is multidisciplinary. Patients who are at moderate risk, who score between a 5 and a 12 on the EDS tool, will be referred to social services. Patients with suicidal ideation will be referred to the crisis social worker. And patients who are at high risk with scores greater than 13, we will call their physicians and have them see a psychiatrist as soon as possible and more frequent follow-up. All of the patients are rescreened by their primary OB/GYN physicians at their subsequent postpartum appointment. So even if you pass the screen in the hospital, you'll be rescreened postpartum. How do we improve our processes? I think the next steps are to develop a comprehensive community resource guide. Everything that we have in place thus far is national, but there are local support groups, psychiatrists, therapists, and complementary medicine providers such as chiropractors, massage therapists, acupuncturists who work with women who have postpartum depression in this area. And so our goal is to try to get a comprehensive guide for our patients. The other thing that we will do is take the feedback from implementation of these changes to improve early identification and treatment of postpartum depression patients. That's it. Thank you.
Thank you. Do we have any questions? Anyone?
Yeah, go ahead, Jake.
The question I had was, has there been any studies to show any difference between mothers who have had natural childbirths and C-sections between this Edinburgh scoring or PHQ-9 scoring or whatever it is?
I don't think there's been a significant difference documented, although if for women who've had traumatic deliveries such as emergency C-sections, there is a slightly higher rate of postpartum depression, and that could be attributed to PTSD.
What is your sense of the general awareness within the public as far as the frequency and severity of postpartum depression and other psychological disorders? Where do you think we need to go as far as educating the public about this? And what do you see the role of the family in either recognizing and supporting referral for treatment?
Well, I think that recognition of postpartum depression is a lot better, even in the last 6 years. Almost every health system has some sort of depression scoring tool in clinic where women at their postpartum visits are screened. So I think the awareness is there, but the education piece, I think, is going to get better with implementation of this legislation. With regards to the role of family, the families should be involved, and our patients should be supported and know that they're not alone, whether it be family, friends, their physicians. We're a community.
All right, thank you.
And I think it's important that we continue to educate
Right.
during because we have a lot of classes that we hold for pregnant mothers and their significant others, and for us to continue to do that education, I think is important. And it is that education up front is always important.
Great.
Any
Thank
more
you.
questions? Thank you, Doctor. Thank you very much. Okay. Good evening, Ruth. Good evening. How about the Service League report?
Hi, the Service League is moving along. So we finished out the year by having our social in December, and in our social, we invite the adult volunteers and we distribute awards for their services for the year. And Mr. and Mrs. Claus also paid a visit to our winter social this year and took pictures with us. What I wanted to just kind of bring to your attention is some of the people that were honored for their years of service, because I think it's just kind of nice to know some of the hours that are put in by our volunteers. So we had Luis Fernandez, who had 12,000 hours to date. Debbie Jackson has 7,500 hours, and Gail Tamita has 6,000 hours. So those are some of our outstanding volunteers that are continuing to serve. Another one that we kind of wanted to recognize were a few people who have years of service. And at the end of this year, we had Karen Bressler with 30 years of service. Carol Purdy with 25 years of service. Cherie Gamardo had 20 years of service. And then we had Charlie, one of our favorites. Charlie has 20 years of service. So just to let you know that the volunteers are here serving and we enjoy what we do, and we look forward to serving continuously next year. And volunteers ended this year with a total of 39,738 volunteer hours for the year 2019.
Well,
Any questions?
No, thank you. Thank you, Ruth. Thank you very much. Okay, back to you, Dr. Killerer.
Thank you. We have, I moved my pages. A total of 586 physicians on staff currently, 360 of which are active. We have 99 ambulatory physicians and 44 that are provisional active at present.
Thank you. Thank you. All right, we're going to move to the
Let's start with the hospital calendar.
yeah.
Past health promotions and outreach events. During the month of December, Lucy Hernandez, Community Outreach Manager, provided 3 hand hygiene presentations for students at Grimmer Elementary School in Fremont. Information was provided on proper hand washing and hygiene to prevent infection and the spread of germs. 76 students participated. Upcoming health promotions and community outreach events. On Thursday, January 16th, from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present A Happier You in 2020. On Tuesday, February 4th, and Tuesday, February 11th, from 10 a.m. to noon, Melissa Reyes, RN, will provide a 2-part education series on stroke. Part 1, Stroke Prevention, will educate community members about prevention, symptoms, and what to do if you are experiencing signs of a stroke. Part 2, Life After Stroke, is an overview on how to better understand your condition and how to move forward after a stroke. On Thursday, February 6th, from 7 to 8 p.m., the Diabetes Matters program will feature Heart Healthy Eating. On Tuesday, February 11th, from 3 to 5 p.m., cardiologist Dr. Sangeetha Balakrishnan will present strategies to help lower your cholesterol and blood pressure. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of December was flu prevention and the importance of flu vaccination, which featured Dr. Diane C. Martin, internal medicine and infectious disease specialist. The Washington Hospital Healthcare Foundation Report. At the end of each year, community and corporate groups make gifts for patients spending the holidays in the hospital. In December 2019, Girl Scouts from Troop 31602 made soft scarves to bring some extra comfort and cheer to our patients. Students from New Haven Memorial High School and the Leo's Club of James Logan High School created handmade holiday cards for hospital inpatients. These cards were delivered to patients by the food and nutrition staff on Christmas Day. Also in December, employees from Boehringer Ingelheim donated several hundred toys that they collected in a toy drive for pediatric patients. Finally, the foundation received more toys from the generous employees at Bishop & Associate Real Estate Sales. The foundation will host the 35th annual golf tournament at Castlewood Country Club on Thursday, May 7th, 2020. Held in memory of Fremont businessman Jean Angelo Pisano, the tournament promises a day of great golf and fun surprises. To reserve your foursome or to sponsor the event, please call Washington Hospital Healthcare Foundation at 510-818-7350. On Thursday, December 12th, community members, hospital employees, and children of all ages gathered in Washington West to enjoy entertainment provided by the Glenmore Elementary Choir, led by musical director Steve Fleminger. President of the foundation, John J. Dutra, emceed the event with remarks by the Mayor of Fremont, Lily May, and Washington Hospital CEO, Kimberly Hartz. Following the program, guests followed Santa and Mrs. Claus to witness the beautiful 35-foot redwood tree being lit on the corner of Paseo Padre Parkway and Maury Avenue. Guests then headed back to Washington West for refreshments and time with Santa and Mrs. Claus. An ASL interpreter attended, as did several members of the deaf community. For some of the deaf children, this was the first time they were able to communicate with Santa, who signed with them about their holiday wishes. It was a memorable evening. Washington Hospital Employee Association, WIA. The Kincaid fire in Sonoma County forced the evacuation of more than 185,000 people and burned 77,758 acres before it was fully contained. According to CAL FIRE, the wildfires destroyed 352 structures, including 167 homes. In response, WIA raised funds and goods to assist our neighbors in Northern California. WIA donated medical supplies, gift cards, and other items at a designated donation drop-off center in Sonoma. Washington on Wheels WOW Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic WOW is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of December, WOW served community members at the Fremont Family Resource Center, Bay Area Community Services BACS, TCV Food Bank and Thrift Store, and the Irvington Presbyterian Church in Fremont, and the Union City Family Center in Union City. These community partners provide social services to families in need and the homeless population. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of December was 24. Internet and social media marketing. Washington Hospital's website serves as a central source of information. The hospital's About WHHS section was December's most viewed webpage with 24,106 views. Washington Hospital has an active social media presence. Through these channels, we update the community with news on events, services, and patient care. Connecting with our community through social media continues to grow. December was a very busy month for Washington Hospital's social media. Several posts focused on holiday activities. Our most popular post told of a Girl Scouts donation to our patients, and this content gained more than 5,000 impressions. Users can find us on Instagram, Twitter, and Facebook at Washington Hosp. InHealth, Channel 78. During the month of December, Washington Hospital's cable channel 78 InHealth aired the December Board of Directors meeting. Additional events and announcements. When baby Preston Yang was born at 12:39 a.m. on New Year's Day, he became the first 2020 baby born at our Washington Hospital Birthing Center. Preston, who weighed 6 pounds 4 ounces at birth, is pictured with his parents and Sandeep Kaur, RN. In honor of our first birth of 2020, Washington Hospital presented the Fremont family with a gift basket. Congrats to the Yang family. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070. And please follow us on Facebook, Twitter, Instagram, LinkedIn, and YouTube.
All right. I'd like to talk about our Employee of the Month. We ring in 2020 with an Employee of the Month who is known equally for her exceptional work and for her infectious laugh. Congratulations to Managed Care Coordinator Patricia Ramirez. Patricia joined the Washington Hospital family as a patient accounting representative in 2004. In 2016, she became the Managed Care Coordinator. Her job requires attention to detail, determination, and most importantly, a friendly disposition. Patricia successfully interacts with several departments, including contracting and case management. Commercial billing manager Pat Mary says, Patricia is a huge resource for her co-workers and everyone finds her easy to work with. Her follow-through on projects is exceptional. Patricia has helped to train new patient account representatives. She has worked through 2 system conversions, and she has brought many outstanding accounts to closure, all with her ever-present smile. Her stellar work ethic is enhanced by her professionalism and her friendly personality. When coworkers comment on her great work, they also include her laugh is contagious. She's a pleasure to work with. Patricia knows that the work she and her coworkers accomplish helps the hospital and therefore contributes to the continuation of providing care to our patients. You could say healthcare runs in the family. Raised in San Francisco, Patricia and each of her 3 sisters work in hospitals. She and her husband, Raphael, live in San Lorenzo, where they raise 2 children. A foodie by nature, Patricia claims she will travel for food, even weekend trips to Los Angeles to go to her favorite restaurant. Patricia and her husband both love to travel. They are planning a trip to Vancouver in January, and in May, her dream trip to Paris will become a reality. Congratulations to Patricia Ramirez as our January Employee of the Month.
Thank you. All right, we're going to move to the reports and start off with the lien report.
Yes, we're going to start with the lien report, and we have 2 guest speakers here this evening. I will introduce both of them. The first is Dr. Terrence Lin. Dr. Lin received his undergraduate degree from Stanford University, followed by medical school at UC Davis School of Medicine. He subsequently did his categorical internal medicine residency at UC Davis Medical Center. His training continued with cardiology fellowship at Loma Linda University, where he was the chief fellow, followed by international cardiology fellowship at Stanford University Hospital and Clinics. He's an adjunct clinical assistant professor of medicine and cardiology at Stanford University and maintains 5 active board certifications in interventional cardiology, echocardiography, nuclear cardiology, and internal medicine. He's been an active medical staff member at Washington Hospital for 10 years and currently serves as the medical director of invasive cardiology services. And then our other speaker tonight is Christy Holt, MSN RN. She has 22 years of healthcare experience. She received her undergraduate degree in nursing from Tennessee State University in Nashville. She later completed her graduate degree in nursing with an emphasis on administration from Middle Tennessee State in Murfreesboro, Tennessee. Currently, Christy is the director of cardiovascular service line at Washington Hospital. She's been at Washington for a total of 3 years. She enjoys spending time with her animals, 1 dog and 2 cats. And this evening, they're going to talk about improving the cath lab procedure supplies. Welcome. Christy and Dr. Lin.
Good evening. Thank you for the introduction. Thank you for having us this evening. So, I have to put on my glasses. We are going to discuss improving cath lab procedure supplies. So the purpose for choosing this issue is a continuation of our previous 5S workshop that occurred in May of this previous year. And 5S stands for sort, set in order, shine, standardize, and sustain. We also hope to improve the efficiency by reducing the number of redundant items that we have in the lab, reduce the staff searching for supplies in different rooms, reduce the overall space needed for cath lab inventory. And this future inventory management will be sustained using the CQVA process. At this last workshop, it was a deeper dive from our 5S workshop, focus on the removal of unneeded procedure supplies used by the physicians. Removing redundant items will reduce the amount of space needed for inventory, decrease the number of inventory locations where staff have to look, which is anticipated to increase our efficiency, so the staff are not running in and out of the room. Reducing redundancy will also lower the dollar amount of total owned and or consigned inventory on hand. And again, we will maintain this, maintain our inventory by the CQVA process. So why is this a priority? We want to drive continuous improvements in quality, safety, value, patient experience, reduce cost, and increase the financial strength and sustainability. But why now? And how do space and inventory fit into our organizational priorities. Because the space constraints in the cath lab, there's not enough space in the procedure rooms for all of our supplies. Having to search for supplies is a barrier to just-in-time delivery of needed supplies to the physician, which can extend the length of time the patient is on the table. Longer time on the table contributes to an increased risk for the patient and is contrary to our organizational patient-first ethic. By working to reduce the number of different types of items and eliminating virtually identical items, our workshop will support the organization's strategic goals of driving continuous improvement in quality, safety, value, patient experience, while at the same time increasing our financial strength and sustainability. Process boundaries. So procedure supplies, we looked at balloons, wires, catheters, and stents, both consigned and non-consigned items. So for this improvement work, our focus was mainly on the balloons, wires, catheters, and stents. These categories include multiple sizes of similar items produced by different vendors and seem to offer the greatest opportunity for streamlining without major impact to the physicians. Non-consigned supplies are purchased directly by the hospital and are stored on shelves and carts in the lab. Consigned items are not owned by the hospital. They are supplied and stocked by the vendor representatives. And although the hospital does not own these until we use them, they take up valuable real estate space in the lab. So at the time of the workshop, our current condition was we had 31 rolling carts, supply carts, not all of which had a permanent location. Maintaining inventory of multiple vendor lines increases the potential for supplies to expire before being used, requires more space, increases the number of locations that staff have to look in order to find a supply. So that keeps coming up. The staff have to look, they have to go. There's not enough space in each procedure room to stock all of the supplies. That's why we have rolling carts. The majority of the supplies are kept on these carts, which allows for maximum mobility. However, due to the limited size of the department, we oftentimes store 4 to 7 of these carts in our holding area and one of our patient bays. So again, we're losing valuable real estate in the lab. Problem statement: too much space required for our current inventory. Supplies expiring off the shelf. Time wasted looking for supplies. So some of the factors contributing to this problem: changes in cath lab management over the past several years have resulted in a lack of consistent inventory management and review, accommodation of physician preferences, addition of new or expansion of existing programs. New inventory items have been added over time without simultaneous removal of older items that may no longer be needed or used. So here is a picture of room 9 and our procedure supplies. It's quite a lot. So again, we have 31 total supply carts that house our supplies, and you can see a few of them there. Most of the supplies are in movable carts, but some are stationary. When a specific balloon, wire, catheter, or stent is needed, and it is not in any of the carts in the room as you see, then someone has to leave the room to look for it. So this is room 8. As you can see, more rolling carts. As you can see, there are 7 rolling carts with roll-up doors that open only from the front, which makes it difficult to keep stock rotated. The supply carts are deep, however, there's space in the back that's wasted space. Because the sizes are arranged left to right rather than front to back, it makes it easier to find the supply. Here is our holding area and a hallway for supply carts, and as you can see, on the first one, that is a bay that we could use to take care of our patients, but we have our supply carts there. Room 7, you see those carts there as well. Room 7 cart. There's the pacemaker cart. It has a permanent location between room 7 and 9. This is the back of room 8 for additional procedure supplies. Because we have so many modalities in the cardiac cath lab, we have a lot of supplies. So it's not just cardiac. We have neurointerventional, we have interventional radiology, vascular surgery, and cardiac cath. I'll turn it over to Dr.
So, hi, I'm Dr. Lin. Nice to meet everybody. So the team gets started. So this process starts off, of course, looking at the workplace. And then we sit around, this may look familiar, a long table and discuss issues. We reviewed the problem statement. We presented the targets and goals of the workshop. Nick Legge came to present support for the project and to be a point to remove barriers during the workshop. So thank you, Nick. And then reviewed data information. This is a nice small text that is showing our targets for our improvement work. We focused on two service lines, the interventional radiology / vascular, which has an overlap of supplies, as well as cardiac supplies. For the vascular supplies, there were near $1 million of equipment on the shelf, and our target was to reduce it by 10% to close to $900,000. For cardiac supplies, we had about $600,000 of supplies on the shelf, and the goal was to reduce it to around $550,000 from this workshop. With the reduction in supplies, we anticipated that we'd be able to reduce the inventory space from 31 carts down to 28 carts to free up some of this room for taking care of patients. These are just some pictures of the collaboration from our team. We had one of the key points is to have stakeholders from every point of the process. So we had physicians, we had a cath lab tech, we had Mohini, a inventory specialist, we had managers, the lean office helped facilitate. You can see people smiling, so it was not contentious the whole time. And really each team member brought a viewpoint to the workshop. What is important to each individual is important all to the team, and to hear everybody's viewpoints on what we can and cannot do certainly helped get everybody on board with the workshop. So this is what those shelves look like on paper. So lists and lists of supplies with quantities and costs. What we did is we looked at utilization reports for the past 12 months to get an idea of what the utilization of each individual product was. We reviewed them trying to highlight products specifically that were used infrequently during that period. We also discussed items that had been reordered multiple times without ever being used. So products that were on the shelf that expired and then were reordered, we highlighted those for review to see are those supplies that were needed in the lab. We identified 3 major reasons for low usage. So the first was that there were mission critical devices that were needed on rare occasion, but make the procedure safer. So these are emergency bailout kind of supplies, and we said these items cannot be removed. We had items that were on the shelf that nobody seemed to know were available, so nobody used them because we didn't know we had them. And then the third was older technology that had been replaced by newer technology, but as we said, the older technology had not been removed. So we identified those as potential items to be removed. A similar process was performed for the cardiac space. We also did get input from multiple providers to try to accommodate to some degree physician preferences. So there are multiple ways to do the same procedure, and the easy thing to say is there's one way that everybody's going to agree to do it, but that does not acknowledge, a 30-year practice pattern. And so we say, is it reasonable to keep 1 or 2 items on the shelf to make sure that everybody is happy and the lab runs smoothly? And so so we identified several products that could be removed without a lot of negative impact. This is a picture of physicians that came. And so we had physicians from interventional radiology, the vascular team, multiple cardiologists come to provide their input and donate their time in the middle of the day to talk about what could and could not be removed. The initial concerns, of course, are always about removing things, and we don't want to lose things that we use on a day-to-day basis. Interestingly, when we presented the data of what was there and identifying substitute items, it was a fairly easy process to say this, and this can be removed because we have these alternatives. We did also, there were several products where we had the stakeholders say, these items are mission critical. We have not used them in 2 years. We hope to never use them, and they can never come off the shelf for that 1 in 100,000 time that it may save someone's life. So we also had discussion about the future evolution of the lab and where the state of cardiology, interventional radiology, and vascular are going in the future, and what are the things that we should do in the short term, medium term, and long term in terms of modernizing and continuing to progress with the lab. So this is what we found in our IR and vascular space. On terms of line item inventory, reduced the inventory from 814 items to 665, so a near 20% reduction in the number of items. That is just physical space on the shelf, so that's fantastic. The value on hand, less impact from a financial standpoint, 992,000 to 919,000, so about a 7% reduction in cost of items on the shelf. As a cardiologist, I will point out in cardiology, we always seek to exceed expectation. For our cardiac pack, we had 618 items that we reduced to 523, so a 15% reduction. And carrying the weight again, a reduction from 610,000 to 525,000, a 14% reduction in held stock. So the total net reduction was a 17% reduction in line items. So as you can see, almost 300 items off the shelf. We had a 10% reduction, right on target in terms of reduction in cost of items on the shelf. So part of this process, though, was to get stakeholders together, to get people talking, to get people working together, to continue this process in the future so that we can say, hey, this is something we need, hey, this is something we don't need, and to try to streamline that process as well. So I think it met those dual aims of creating communication, identifying a process, and identifying items. This is the implementation plan. So this is the sort of result of the workshop. There are recommendations for removal and alternatives. That's from the team. We present those recommendations to the cath lab section committees for approval. At that point, once there's approved, then we send to vendors to adjust items to be removed. At the next step, once those items are removed, then we talk about segregating and relocating, so basically reorganizing the carts to consolidate that. And then for items that are not consigned, so items that we own, that are on the shelf, that will someday expire, to develop a plan to say if this is a reasonable, safe, and appropriate usage to earmark those things for usage to use up that existing stock so that we don't lose out on those things. And of course, 5 is sort of the same thing, again, reorganizing the space within the rooms with the reorganized carts. Long-term improvement ideas, and this is for me one of the more exciting things. Item number 1 seems like a simple thing. These carts are double deep carts, and the back half is empty, and you can't stock the front of it. So one of the things that we've asked is to obtain quotes for new carts, these are surprisingly expensive metal boxes, but as a one-time cost, if you can, for instance, stock the front and back of the cart, you can double your effective space as a one-time cost and forever, which improves the utilization of space, it improves the efficiency of inventory, it improves the amount of items available in one room. So for that one-time cost of a cart, you can fix 3 or 4 problems, or improve 3 or 4 problems. For item number 2, we talked about multiple stockings of carts. This is the idea that if you have too much stuff to put on one cart, you have to put it on 2 carts. If you have 2 boxes and you separate them, you never know what's in each box. So the idea is if you can consolidate, you can just put it in one box. So 3, a par level is the amount of consigned equipment that you have on the shelf. There's a concept of having a just-in-time or just enough stuff concept. And I will say that our par levels, one of the findings is our par levels are not optimized across the board. And so identifying a process that we can adjust the par level to be appropriate now and to have a process to readjust it so it's sort of a live readjustment of inventory based on your volume. This allows for growth without having too much stuff on the shelf. And then the 4th is, even with all of these improvements, we are limited by the physical plant. And so there's a question about, could we find more space to, as we grow the programs, is there more space that we can find to sort of optimize storage and availability of equipment? So, there are multiple pictures of teams, mainly because not everybody fits in the same picture at the same time, but these are all the people that participated. And we'd like to thank Kimberly Hartz for supporting the project, of course the Board of Directors for supporting of us in this journey of efficiency and continuous improvement. Thanks.
Thank you. Any questions? Very good work. Thank you, Doctor.
Thanks.
Thank you. Christy. Okay.
All right. Next we have Mary, and she is Mary Boron, and she's going to be presenting the infection prevention program for 2020.
Thank you. Good evening. Tonight I would like to go over our plan and approach for the management and implementation of our infection prevention program for 2020. I want to start off by saying that I think that the success of the program and our outcomes are largely based on having a strong commitment from our executive leadership team, creating a patient safety culture here, and lastly, making sure that we're making all the interventions possible that we can empower our workforce and staff so that they can be focused on process improvement. So I think you'll see that each of those elements exist in how we develop and maintain this program. So why do we need an infection prevention program? First of all, the research on this over the last 10 to 15 years has increased drastically, and the numbers are pretty staggering. The average amount of healthcare associated infections that happen in the United States every year is about 1.7 million still. And specific to California, there are about 240,000 patients that are admitted to hospitals and suffer an illness associated with exposure to being in a hospital. But the good news about it is that we have discovered many ways to prevent the spread of these infections. And through education, awareness, and implementing evidence-based practice, we have been able to see some success in prevention related to hospital-associated infections. The core of this program is really developed and sustained through the Infection Prevention Committee. This committee was developed in 2006, and so with that time, we've been able to develop a lot of our process improvement and identification of issues we need to be focused on through the membership in this committee. It is led by Dr. Martin, our infectious disease consultant. She's very committed to the prevention of spread of infection in the hospital, keeping our staff and patients safe. She works very closely with our program manager, Ruda, Michelle, and they work together as a team to lead this committee. But I think what's more important to focus on with the committee is that there is a rep from every department of the hospital on this committee. They meet monthly, and that requirement is necessary because really infection prevention is not just the infection prevention team, it's the entire hospital is responsible for it. Whatever your role is in the hospital, if you work in EVS or if you're a surgeon, nurse, whatever it is, you have a responsibility to participate in reducing the risk of harming patients through spreading infections. So I'm glad to say that ours is very well developed and we have a strong membership. For the components of the program, they're obviously based on improving and providing the best quality that we can for these patients and keeping them safe while they're here. That is done through multiple focus areas that I'll be going over in a minute, and looking at how are we keeping our staff and our patients educated related to infection prevention, and staying current with evidence-based practice. Like I said, there's a lot more research coming out all the time on how we can prevent these things. So that's the development and the program components that we focus on. There is also a large federal, state, and county focus on infection prevention in hospitals, and rightfully so. The regulatory bodies are very aware of the risk that occurs in hospitals and want to monitor hospitals to see what we're doing to prevent it and what our incidence of infection. So these are a few examples of how we report it out on a national level to NHSN, which is part of the CDC. All of our data goes to them quarterly, and it's nice because we get analysis feedback from them. CMS, the Centers for Medicare and Medicaid Services, have a long list of requirements that we submit to them and they share within the NHSN database. And of course, our California Department of Public Health, and right here, our Alameda County Public Health Department. So these are groups that we work with. It helps us stay in touch with national standards, and we are obligated to share our data with them. There is also a strong foundation that the program is built on related to Joint Commission National Patient Safety Goals, which I think a lot of us are familiar with. But patient safety goals were developed to, of course, improve patient safety. But what I think is good about the way they're developed is they are developed by looking at evidence and research that is centered around what we know are problems in healthcare. And they set goals that they want us to focus on because it's a known problem and we have to look at how we can continuously make improvements. They have a dedicated goal to infection prevention. It's goal number 7. They update it. In fact, every year we get a manual and it's updated around what areas they think, based on what they have seen across the nation, we should be focusing on. So currently in 2020, it'll be, of course, a continual focus on hand hygiene. They would like us to comply with Centers for Disease Prevention or World Health Organization standards, and implementing evidence-based practices that will prevent device-related infections. These are your catheters mostly. And looking at what we can do to manage multi-drug resistant organisms, which are increasing as a problem in healthcare and actually throughout not just the United States but the world. It's becoming harder to treat certain bugs, and so we have to manage them very carefully when they're identified in the hospital. And surgical site infections. So these are patients that are at risk for, when they have surgery, developing a surgical site infection. There are certain procedures that they focus on more closely, and we monitor those and report those. So those are the areas that really sort of guide our plan for how we're going to manage the program. Every year we are also take an opportunity to look at our data and analyze it and use it to improve process. The thing that we don't want to have happen in any program, but especially infection prevention, is to be data rich and be spending all this time collecting data, but not implementing it to make process improvements, right? So it's nice to step aside once a year. We do this with Dr. Martin and the members of the infection prevention team. We look at all the data over the last year and we use it to implement it into a risk assessment. This is a standardized tool that's used across most hospitals, and it really helps you identify where your areas of risk are. What have you seen a lot of, like, for example, if you've seen a lot of TB, you're going to have to put extra resources into maintaining and sustaining your TB exposure plan, or maybe you had an issue where device hospital-associated infections increased. So what are you going to do to make that a priority in the coming year? So this sort of is our guideline for the program. And as I mentioned, it requires really reviewing your data. I have a couple of examples over here of data that we looked at related to device infections. C. diff is one that, as you can see, it's, we've been able to have a lot of success on sustaining it and keeping it lower, which was in the prior years a problem. So I know that we want to sustain that, so we need to dedicate resources to it. Same with surgical site infections and, of course, hand hygiene. So this is some of the data that we use to review. We also need to take into consideration what's happening in our community. What are our patient population at risk for, right? So it's different. Your risk for living in the Bay Area, California, and communicable diseases are going to be different than if you live in the Midwest. So you really have to look at your patient demographic. For us specifically here, this year again, we have recognized that we'll have to focus resource on the prevention of TB, tuberculosis spreading, and identifying it early in the hospital, patients who are at risk, and making sure that they are put on airborne isolation so that we don't spread it, and that we treat it appropriately for them while they're here. Because, as you can tell by looking at the red line, which is the top line, which is Alameda County, our specific county is even higher than the national California average, and overall U.S., the purple line, you can see we're significantly above that. Our Alameda County recognized that in 2018 it started to go up again, and so that is the number of TB cases, for example, were 10 per 100,000. 18% of that is here in Fremont, which may not sound like a lot, but it is when you're dealing with TB, and so we have to treat this very carefully. So we recognize by this data that that'll have to be a priority. So after looking at the data and recognizing where our risk is, the next question is, what are we going to do about it? What are we going to do to prevent the spread of infections? And what's going to be our strategic approach and focus? So what we recognize, again, like I said, was very largely they are connected to the Joint Commission National Patient Safety Goals, looking at hand hygiene, device prevention, and things around C. diff and TB, antimicrobial stewardship. The approach that we have, the strategic approach to do that, is very detailed in taking day-to-day management of investigating our hospital-associated infections that do happen here, assuring people are using the personal protective equipment will be one area that we'll focus on, because that's your key to stopping infections from spreading. We need to continue to look at our devices daily to say, do they need to be in the patient? Is there a medical necessity for it? Are we maintaining devices, cleaning them, and making sure that they're covered and maintained in a way that meets a national standard for a bundle compliance? That'll be a big focus for us this year, because we did see some increases. We've had spikes and increases with device related with CLABSI and CAUTI. So we're going to continue to look at that bundle maintenance. High-level disinfection. So these are instruments that are used with patients that are very risky if not cleaned properly on spreading infections. This is going to be like endoscopy, things like that. We really want to focus this year on utilizing what we know from evidence-based incidences that have happened in other hospitals, and applying process improvement to make sure that we are reducing the risk of scope transmitted diseases, because it's been an issue in many hospitals. And the other thing is we have to have daily presence in the hospital. The hospital has a workforce that is very committed to wanting to do the best for the patients, and we need to have the presence there to educate them on our policy and procedure and be available as a resource to them when different things are coming into the hospital, and they have a lot of questions about how to manage the patients appropriately. So we'll continue to make sure we have that presence this year. Working closely with EVS is another key component, which I'll be talking more about in a minute. Looking at our highly infectious disease plan, these sort of things will be our strategic approach to improving it. We have to always maintain surveillance of certain things that we know are high risk to happen in the hospital. And I've mentioned a couple of them already, but influenza is another thing that we focus on here. And that's why we do annual education with the staff and with patients. And Dr. Martin's a huge part of that program. We do that annually. And another thing that you may seem odd is that infection control is actually involved in providing a risk assessment on construction that happens in the hospital. Most of this, of course, would be inside the hospital construction. And this is also a regulation. And it's because in construction, certain things can be aerolized and there's dust and things, and you don't want to expose patients who are already sick to those sort of things. So infection control works closely with that team to ensure that patients are kept safe while we're doing construction, and that barriers are put into place, and that we're communicating daily with them and rounding to make sure that those elements are sustained. They're basically safety measures to protect patients and our staff. Water management is another thing that's become a focus, especially since 2018. Our federal database at NHSN has actually required us to submit an annual plan for how we manage our water. And the long and short of this is that we have to do practices with testing water to make sure the water is safe and usable for everybody in the hospital. So an example of when we did this is when we opened the Morris Hyman Critical Care Pavilion. There was a lot of testing done around that to ensure that the water was safe and ready to go prior to use. Environment of care is everybody's responsible for keeping the hospital clean, right? And for making sure that we clean instruments and things between use of patients. That's obviously a huge part of stopping infections from spreading, is keeping your environment clean. But the real people who are the backbone of this program are our EVS team. We have a great EVS team here. They are very committed to how they clean rooms, how they turn over rooms, right from the OR and procedure areas all the way to patient rooms. And I cannot emphasize enough how much that improves patient safety, because a lot of these bugs, as you know, live on environments. I mean, C. diff has been known to live up to environments, surfaces for 60 days. So if you're not bleaching it off of a surface area, you're putting risk to patients who are in that room. So I'm very happy to report that they take that commitment seriously, and we've seen some good outcomes from it. Antimicrobial stewardship is basically how do we prescribe and monitor the use of antibiotics here. You're going to be hearing more from Dr. Martin about this next month, and it's basically a team of interdisciplinary people who look at how we manage our antibiotics. One of the key differences that I'm happy to report we have here is we have a dedicated pharmacist consultant that works closely with Dr. Martin to ensure that this is happening on a continual basis, so that patients are getting the right antibiotics at the right time. Keeping our patients educated is another key component of the program, especially related to communicable diseases. It's a great opportunity while patients are here to talk to them about influenza and how it spreads, or to talk about hand hygiene, personal protective equipment, how should you manage your illness when you go home, to keep your family safe. These sort of things occurred every single day in this hospital. It occurs from physicians. The bedside nurse does a lot of education for the patient. But in addition to that, we also provide an LVN who, a huge part of her responsibility is to go into every patient here who's on a form of isolation, who has an identified infectious disease, and provide written education and dedicate some time to have a two-way conversation to assess the patient's needs and gaps in knowledge. And that is a key component of the care plan, and it's actually required by Joint Commission. And so we are doing that on 100% of the infectious related conditions that we have in the hospital. Staff education, the same thing, just as important. I've already touched on this a little bit with the importance of keeping our staff aware of what are the new evidence-based guidelines, and giving them educational material. We do patient safety blitzes, and we also provide all new hires with education prior to them being into the hospital. But what I think infection prevention gains even more from staff education is there is a lot of communication between the staff and the team, where we learn a lot of things about what they're dealing with out in the environment and the gaps and barriers that they have and they're dealing with. And one of the things that came up in the last year and a half was what type of patients need to be tested for C. diff, and what are the signs and symptoms, and how do we test appropriately, right down to getting an appropriate specimen that's good for testing. And we developed this example here of the C. diff testing decision flow chart. This went through multiple revisions because it went through the medical staff quite a few times. It went through nursing quite a few times, and they gave us a lot of great feedback on what they thought would make this a real feasible tool. we implemented it and therefore are testing more appropriately. And I think that that has had an impact on making sure that we're not over-treating C. diff, and making sure we're treating it appropriately. So that's an example of how we've used it. The future direction of the program is to maintain basically all of the elements that I've spoken to and to move further into continuous process improvement. And that would be by looking at making sure we have good initiatives and improvements. But the overall goal is that we want the program to get to the point where every patient is getting the same care at the same time, and we're reducing their harm, the risk of harm happening to them, and improving all of our process to do that. Thank you.
Thank you, Mary. Okay. Finance,
next.
yeah.
We have financials.
Yep.
Okay, tonight we will be looking at the operating and financial results for Washington Hospital for November. And as always, we'll look at our acute census statistics. Average daily census admissions and patient days for the month all landed between 9 and 10% below budget. And these numbers were also significantly lower than November of last year. The average daily census and patient days were off about 4.5%, and admissions were off 12%. So really lower than we'd seen last year and lower than we had expected in the budget. Outpatient observation equivalent days for November came in at 199. That was 47 better than budget. And our average length of stay based on discharges came in lower than budget at 4.68. We'd expected 4.95. That has actually been an area of focus. We've been trying to lower that length of stay. If you recall, over the past few months, we've seen that number between 5 and 5.5. So some good work being done there as part of that reduction. Looking at utilization, case mix index for the month came in almost right at 1.5, a little bit lower than what we expected in the budget. Deliveries for the month were low at 117. Those numbers have been a little bit volatile the last few months, bouncing between this and I think you'll see a higher number in Kimberly's report in a few minutes. It's just been kind of up and down. Surgical cases for the month came in at 366. That was 46 below budget. And really, that unfavorable variance spread across most of our major product lines with the exception of neurosurgery, which came in one procedure higher than budget for the month. Outpatient visits for the month continued high, 700 above the budget. Again, really being driven in the same areas that we've been seeing it. Really across the board, we're seeing higher activity, but really in the lab and a pharmacy with the higher activity that we've seen in the cancer program here at Washington Hospital and the infusion center driving those numbers. Emergency room for the month came in 153 visits above budget at 4,237 for November. Quick look at cath lab activity. No real surprises here. Peripheral vascular and cardiac activity continue to dominate the activity in there, and peripheral vascular really the highest level of activity again in November. Looking at productivity, productive FTEs for the month came in lower than budget, 1,271.3. We had higher non-productive FTEs at 210.7. And that's just a good indication that because volume was lower, management was trying to get people out on vacation. And this is also a holiday month, so we see a higher level of vacations anyway. So our total FTEs came in 16.8 above the budget at 1,482. Our full-time equivalents per adjusted occupied bed however, came in pretty close to budget, just a little over at 6.55. So staffing pretty close to where it should have been given what was going on in the operation. Moving into the financials, total patient revenue came in 6.2% below the budget at a little under $165 million. Our contractuals for the month broke out with actually our write-offs for our insurance-covered patients were a little bit better than expected as a percentage of gross revenue. 75.6% of gross revenue against a budget of 75.27. We did have some favorable payer mix in there within those contracts. Our provision for bad debt and charity as a percentage of gross revenue came in a little worse than we expected, and that number has been trending up and down over the year. This month it was up at 2.68% of gross revenue. We had budgeted 2.38%. So our total deductions for the month came in just a little bit over budget, pretty close at 77.74%. We had budgeted 77.65%. So we ended the month, and again, this is the Governmental Accounting Standards Board presentation. We ended the month with net operating revenue about 6.6% below the budget at $37 million, almost $37.2 million. Operating expenses in November came in $245,000 below budget. We've got a few things going on here. Salaries and wages were a little bit higher with our higher FTEs. Benefits came in $84,000 above the budget, and we got a couple of big offsets going on here. We did have our $550,000 adjustment we've been making to our pension and post-retirement benefits this month, but that was offset by lower health and welfare claims of $156,000. Our workers' comp claims were down about $58,000, and we had lower payroll taxes during the month. When we get to the end, start getting towards the end of the year, there's two tax items that have caps on them. One is state disability, the other is Social Security. Really hard to project a year out how many employees are going to hit those levels and when they're going to hit them. And we started to see that hit in November. So those payroll taxes were lower than budget. We had purchase services were below budget, $242,000 in the month. And again, the medical fees we're paying for the services we get through UCSF for the prenatal diagnostic center, our oncology program, and special care nursery were lower than budget as they continue. Their activity is higher than we expected, and as a result, the fees go down. Those really were the two main drivers in operating expenses for the month. So we ended up with operating loss in the month. Expenses were lower, but not low enough to cover the lower revenue. So we end up with a $2.2 million loss from operations in November. Non-operating income, likewise, was below budget, about $300,000. We did have a $363,000 unrealized loss on our investments for the month. So we ended up November with a total bottom line from a GASB perspective showing about a $2.5 million loss. Looking at our Financial Accounting Standards Board presentation, so this includes the adjustments that Wall Street might make when they look at our financials. We reclassify, first thing we do is reclassify the interest expense on our revenue bonds back up into operating expenses. So that changes our operating expenses to about $40.1 million for the month, and changes our operating income our operating loss to about $2.9 million. When we take a look at our non-operating income from a FASB perspective, we eliminate that unrealized loss on our investments. We also eliminate our property tax revenue that supports the GO bond debt service and the related interest. So we end up with non-operating income from a FASB perspective of $524,000 and a total bottom line of about $2.4 million loss. So these losses, they're not good. But what does it mean for us from a cash perspective? And this is why we look at earnings before taxes, interest, depreciation, and amortization. There are numbers, the largest of which being depreciation in that income statement, that don't represent current cash flow. That number represents past cash flow. So we like to look at this number because it gives us an idea of what cash looked like as a result of operations. So we pull our depreciation expense out of those operating expenses and compare them to our net operating revenue, and we come up with EBITDA that's actually a positive number of a little over $1.8 million. Likewise, if we go down into our non-operating section, we separate our interest expense out to see what our non-operating activities generated in cash or available cash, and that number ends up being about almost $1.6 million. So in total, the operating and non-operating activities provided about $3.4 million to cover our debt service and future capital and other needs in November. So are there any questions on December? Okay.
Great. I'm going to give the preliminary operations report for December. It was, you'll see that it is a better month than November. And to start with, in terms of looking at gross revenue of $176.6 million for December, which was above budget by $5 million or 2.9%. And you can see that inpatient gross revenue of $117.7 was below budget by $3 million, but outpatient gross revenue of approximately 59 was above budget by $8 million. We've also done some preliminary look, and it does look like our net revenue is going to end up a little over $2 million above budget when we take into account net revenue. So that is good in terms of looking at December. Moving on to the revenue variances and the major drivers, you can see, you will also see that our days are down. So that is also, our room and board revenue is down by $1.1 million or 3.2%. And then you can also see, just picking out the highlights, the cath lab procedures were above budget by 45.9%, driving cath lab revenue up by $2.4 million or 17.2%. So you can see sort of some of the main drivers of our revenue variance for the month of December. Moving on to, the key census statistics. As I said, you can see that the average length of stay of 4.6 was below budget of 5.02. We looked at it, and really a lot of the decreasing days compared to budget was around the procedure volume. So, we are doing a better job of looking at our lengths of stay and ensuring that we get people out appropriately. Also, you can see outpatient days were 52 or 31%, almost 32% above the budget. And our average daily census of 147.3 was below budget of 158.1. And again, you'll see that our days are down from that. And admissions, you can see we were pretty much right on budget at 977 compared to a budget of 976. And then looking at patient days, this is where you'll see that our patient days of 4,566 were below budget by 335 or 6.8%. Our surgical trend, total surgical cases in December of 365 were above budget by 13 or 3.7%. Our inpatient surgeries were 4 below budget or 1.9%. And our outpatient surgeries were 17 or 12% above budget at 158. So it was our outpatient surgeries that were above budget. Just looking at our general surgical activity, as you can see, our joint replacement surgeries were above budget by 12 or 10%. And then, unfortunately, our neurosurgery cases, we had a few neurosurgeons that were out of town during some of December, and they were below budget by 6 or 23.1%. The cath lab trend, you can see, the procedure volume continues to increase. We had procedures for December of 521, which were 164 or 45.9% above the budget. If you look in breakdown between inpatient and inpatient cath lab procedures were above budget by 86 or 43%. And outpatient cath lab procedures were also above budget by 78 or 49%. So pretty much a split between both inpatient and outpatient. Looking at the breakdown of our cath lab procedures activity, you can see the neuro IR procedures were above budget by 6 or 86%. Also, the peripheral vascular procedures were above budget by 145 or 101%. Deliveries, we had a good month for deliveries. They were above budget by 6.5%, variance of 9. Looking at our non-ER outpatient trend, again, we continued the trend of increases. We've seen an increase compared to budget of non-emergency outpatient visits of 7,289. We're above the budget by 457 or 6.7%. Some of those areas that saw the increase, we saw infusion center visits were above budget by 43 or 13.4%. We also had x-ray visits that were above budget by 35 or 2%. And the other that was a great deal above budget, we had short stay visits were above budget by 97 or 85.8%. Also, we saw an increase in our emergency room visits compared to budget. They were 4,618, were above budget by 317 or 7.4%. Looking at our productivity indicators, productive FTEs were above budget by 15.3, 1.2%, and non-productive FTEs were below budget by 31 or 11.3%. So our total FTEs were a little bit over budget by about 1% at 15.7. If you look at our productive FTEs per adjusted occupied bed of 5.72, we're above the budget of 5.55. And total FTEs per AOB were pretty much right on. They're a little bit over by 0.6%. Other operational statistics, Washington outpatient surgery center cases were below budget in December by 126. We had, one of our endoscopy physicians was out of town, and so we had a couple of other physicians that were also out of town during December. You could also see clinic visits were below budget by 3.1%. We had urgent care that was above budget, but we did have the Nakamura and Warm Springs Clinic that were below budget. Looking at our preliminary payer mix, you can see that our government-sponsored patient revenue made up 69.5% of total gross revenue, which is below the budget of 71.9%. You can see that our HMO revenue was 2% of gross revenue. Especially to note, we had a favorable payer mix of our PPO at 26.6%, which is higher than the budget of 23.2%, which has helped our net revenue potentially be above budget. Going on to our key financial statistics, our days cash on hand, we're at 166 compared to the prior month of 168, compared to the prior year of 164. We did have some pension funding that we made for $6.6 million, so that's one of the main reasons driving our days cash on hand down from the prior month. You can see our days of gross revenue and accounts receivable were 55, and our charity care did tick up to $746,397 for this month. And lastly, you can see with the homeless patient activity, there were 227 homeless patient encounters. We did see an increase. Incremental cost for December was $116.23. And the total unreimbursed cost of homeless care year-to-date is approximately $2.8 million. So we did see some increases in that area too. Any questions?
Questions? Okay, well, thank you. Thank you. There are no action items that we haven't already considered under the consent calendar. Kimberly, you have any other announcements?
We don't have any announcements.
Okay. And we do not have a closed session.
We do not.
So seeing that there is no closed session, this meeting is adjourned. Thank you.